following presentation is part of a certified educational activity provided by Medscape Education and supported by educational grants from Amgen, AstraZeneca, Daiichi Sankyo, and Novacure. Hello, I'm Dr. Stephen Liu, Associate Professor of Medicine and Director of Thoracic Oncology at Georgetown University in Washington, D.C. Welcome to this program titled Expert Insights on the Management of Lung Cancer, a podcast series. I am privileged to be joined today by Dr. Jared Weiss, Professor of Medicine in the Division of Oncology at the Lineberger Comprehensive Cancer Center, University of North Carolina in Chapel Hill. Jared, thank you for joining us today.
Thank you for having me here today.
The topic of today's podcast is what's on the horizon for KRAS-mutated non-small cell lung cancer. And this is certainly a rich topic. KRAS is a gene we see very frequently altered across cancer types. This stands for Kirsten-Rath sarcoma virus. KRAS is an oncogene, and it is frequently mutated in human cancers, including, relevant to today's talk, non-small cell lung cancer, where we see mutations in KRAS in about a quarter of all cases. It's top of mind lately because we finally have effective and approved targeted agents for KRAS, but this is by no means a newly discovered mutation. Dr. Harold Varmus won the Nobel Prize in 1989 for work done on MYC and KRAS. As a genomic event in cancer, there's a lot of history around KRAS, but this alteration is fundamentally different from EGFR mutations, ALK and ROS1 fusions. Jared, care to elaborate on that?
So there are a number of ways this mutation is different. I think the first is to note that we have isoforms for this mutation, unlike the more limited isoforms in some of the mutations we're more familiar with. At the most basic level, we have KRAS, HRAS, and NRAS. KRAS is the most common, but even then you have to subtype it. G12, G13, and Q61 being most common. Our focus today, because it's now actionable, is G12, particularly G12C. And so you mentioned that KRAS is about 25% of adenocarcinoma. G12C specifically is about 13% on an absolute basis. Here, the demographics are also a little different than some of the mutations that are more commonly discussed in lung cancer, like EGFR, ALK, RET, and ROS1, and that the majority of patients do have a smoking history. In the code break data that I'm sure we'll get to, only about 5% of those patients had never smoked.
And when we think of sensitizing EGFR mutations, ALK fusions, these sort of result in a constitutively active kinase, a receptor that's constantly on, and we can develop drugs to sort of block that phosphorylation. KRAS has been a little different there, right?
Yeah, so if you think of that canonical MAP kinase cascade that all of our fellows have to memorize, right? You have EGFR to RAS to RAF to MEK to ERK to nuclear badness. And certainly to be active, RAS does need to localize to the cell membrane. There's a long history in farnesyltransferase inhibition and trying to stop it from getting there. But it's not quite a receptor tyrosine kinase the way EGFR is. It's one step downstream, and it requires a lot of help in its docking, which leads to some of the combinatorial approaches that are in vogue in trials right now. And so it does signal between a GTP on and a GDP off state, and that'll become relevant to our mechanism of action of the drugs we're going to discuss, which hold it in a GDP inactive state.
Now, you're mentioning a lot of letters and numbers to the uninitiated. The nomenclature here is really important because, as Jared mentioned, there are different types of KRAS mutation. So in non-small cell lung cancer, we're usually talking about codon 12 and 13. And as you mentioned, the most common KRAS G12C by itself, 13% of lung cancer. Within KRAS mutations, about 40% of cases. Next most common would be G12V and then G12D. What the letters and numbers mean is, G12C means at position 12, the amino acid G, glycine, is changed to the amino acid C, or cysteine. And G12V would be glycine to valine and so forth. And there's a lot of variation. These mutations do occur across histology, much more frequent in non-squamous than squamous. And there's a lot of geographic variation too. While this is very relevant to our practice here in the US, KRAS mutations in lung cancer, not as common in other parts of the world, right, Jared?
Absolutely. So for example, I think the classic is you expect EGFR at a higher rate in Asia. I'm in the tobacco belt, so we see even within the US, we see a disproportionate share of KRAS. I think it's important to note that these differences that you're mentioning lead to differences in shape. And it's these differences in shape that are why you can't drug G12D or G12V with a G12C inhibitor. It actually is specific. You're just not going to hit the pocket right. It just isn't going to work. It's not that it doesn't work as well, and you can consider it as a late line regimen. It's just ineffective. And in case that's not complicated enough, having isoforms and subisoforms and all these shape questions, the biology of resistance and the relevant signaling and the efficacy of drugs is different across cancers. And this is really important to talk about because for years, we've all been trained that the mutation matters more than the cancer in which it comes. That if you have ALK, you have ALK. If you have NTRK, you have NTRK, et cetera. And while I'm an adherent to that religion, unfortunately, in the case of KRAS, the signaling pathways are far more complex. You have a lot of KRAS independent signaling in KRAS dependent cells. You have a lot of crosstalk. And so the biology in, say, colorectal cancer is not the same as the biology in lung cancer. And so you're going to see, unlike the paradigm we had all been trained to expect in sort of a wash, rinse, repeat method across molecular changes, in the case of KRAS, we're going to see, we already have, and we're going to see more of indication and context specific approvals. And so unfortunately, we're going to have to learn these in a disease specific way.
Yeah, all these details make a big difference. So we need all of these details. Let's jump right into therapy. KRAS for decades was considered an undruggable target. There were many different strategies, many trials that we're both involved in that simply failed based on solid preclinical science, but they just didn't translate for various reasons. Finally changed on May 28th, 2021, the US FDA granted accelerated approval to sotorasib for KRAS G12C mutant lung cancer. Jared, can you talk a little bit about sotorasib, how it works, and what those data showed?
Sure. So sotorasib was really an advance in structural chemistry in that it had been a shape problem for people with probably more PhD after their name, for scientists to solve for many years on how to drug, how to fit in the pocket to bind G12C. And sotorasib and adagrasib, which is not approved, were really the first to be able to actually do this, to be able to bind to KRAS G12C. And what they do is they hold it in the GDP off state. And so that it cannot signal downstream. Now, you can get feedback inhibition around this and other pathways, but in terms of the canonical downstream pathway, it holds KRAS in its GDP off state so that it can't signal downstream, ultimately getting to the nuclear badness and cancer proliferation.
And we saw some data presented over the past few years that's evolving, becoming more mature. We're talking about the code break data that really showed efficacy and served as the registrational data set for sotorasib. Jared, can you talk us a little bit through the efficacy there?
Sure. So the response rate was 37% in CodeBreak for single agent sotorasib in lung cancer. Disease control rate was 81%. And critically, the PFS was 6.8 months. The side effects were mostly GI along the lines of, I think, somewhat familiar to us. Grade 1 and 2 diarrhea in 28%, 4% grade 3, 19% of patients having nausea, I think all grade 1 and 2. The LFTs went up in a way that I think we're rather used to across the kinase inhibitors. Fatigue, of course, and pneumonitis in 1 or 2% of patients. Not so much rash, the way we're used to with EGFR, but really, I think the GI spectrum that we're used to from kinase inhibitors in general.
37% response rate. This was, widely lauded as quite an achievement, led to the approval here. But if I'm looking from the sideline, 37%, it's a lot lower than we see with ALK inhibitors, with EGFR inhibitors. Should we be excited about 37%? Is this something you were expecting?
I'll be honest with you, this is better than I was expecting. There's so much KRAS independent signaling in KRAS that I was really skeptical that we were going to get out of the single digits for response rate. And I'm thrilled to be wrong about that. Absolutely thrilled. So, no, this actually vastly exceeded my expectations, both in response rate and in durability. And so I think I'm very excited as a clinician to have this as an additional tool for my patients. As an investigator and as a clinician who has to make decisions with the patient in front of me, I think the more critical question is, am I excited enough for the total profile that this is a frontline drug? Now, of course, when you give drugs frontline, they work a little bit better typically than when you give them next line. If I remember correctly, the PFS went up to about 11 months with, if you told me I'm wrong, maybe by a month, I wouldn't argue with you, but about 10 or 11 months when you went to frontline with sotorasib. And once upon a time, that would have been good enough, right? So if you go back to when we were in training, early training, let's say late med school, early residency, that would have been great, right? The bar for true targeted therapy for PFS, 11 months would do the job. And with gefitinib, we were seeing a 60% or so response rate. But at that point, you're comparing against carbotaxol, right? I mean, we're not even in a pemetrexed era back then. Fast forward to modern times, and if you think about KRAS, unlike EGFR, ALK, probably RET, probably others, KRAS is not a negative predictor for immunotherapy efficacy. In fact, because if you have KRAS, you don't have EGFR, ALK, or RET, in effect, by excluding those patients with negative prediction, it's actually a little bit of a positive predictor. There's more complexity one could go into. I'm going to intentionally not, but keeping it at that level, it's a bit of a positive predictor. And so if you think about what we get out of triplet or in the PD-L1 high out of pembro monotherapy, this just doesn't hit the bar, right? The 37% response rate, a PFS, whether you want to call it the overall 7% or the 10 or 11 months in frontline, doesn't hit the bar. And further, as you've alluded to, in the era of targeted therapy of second and third generation drugs, thinking about alectinib for ALK, thinking about osimertinib for EGFR, I think we've raised the bar in a very happy way where we're really looking for a PFS of more like 20 months. And so in the current context, whether you're comparing critically to other TKIs for other mutational states, or whether you're comparing perhaps more appropriately to the alternative options available to us, such as triplet with immunotherapy, to my mind, this just doesn't hit the bar. And so I'm excited. It's a wonderful second line option. In my opinion, if you're comparing this to dosi or dosi-ramu, looking at the toxicity profile, looking at the efficacy profile, I find it a preferred second line regimen over dosi-ramu for my patients, but not hitting the bar for frontline.
Yeah,
do you have a similar perspective or anything to add to that?
I do. I think it's really well said. When I think of what we can achieve in the frontline setting for KRAS mutant lung cancer, you're right. It's very different with immunotherapy. And it's kind of easy for EGFR, for ALK, for other targets, because you've got very effective options that work very, very well. And immunotherapy does not work well, right? with prospective response rates in the frontline setting of 0%. So, it's an easy decision here. But for KRAS, the response rate, the outcome's not quite to that bar, as you mentioned, it's been elevated, but also immunotherapy can offer benefit, does offer benefit. And, whether you want to use the word cure or not, there are going to be some patients that get very durable, meaningful responses, long-term survival with immunotherapy. And there are no guarantees in lung cancer, so I wouldn't want to forfeit. I wouldn't want to sort of risk depriving someone of that potential benefit. So to me, KRAS G12C, my frontline treatment is immunotherapy in some form, and so immunotherapy-based treatment. And I agree that in the second line setting, that the comparator there is docetaxel ramucirumab, where your response rates are in the low 20s, and relative to that, yes, I also very excited by a 37% response rate. In my practice, sort of, now that the drug has been approved, we've had some use for it, I would say my experience has been very favorable. I find this to be an extremely well-tolerated drug. And for me, most of the toxicities I've encountered in my own clinic have been sort of paper toxicities. Jared, your practice, is it echoing what you see in the paper, what you see in the trials?
I would call it well-tolerated. I might take out the extremely, because I think if I compare it to osimertinib or alectinib, where we have more historic experience, I find those a bit more patient-friendly than sotorasib. But yeah, I would call it well-tolerated. And it's easy to compare it to dosi-ramu. In my opinion, dosi with or without ramu is more toxic than the historic literature lead us to believe. If there's an axis of doc, I feel great to doc, I feel awful that goes a little bit beyond the toxicity tables, I've always found dosi to be a rougher drug than the numbers suggest. I think the sotorasib data tells the story pretty accurately.
Yeah, I agree. Now, fortunately, this is not the only drug we have in development. We've seen some data from adagrasib. Jared, are you familiar with that data in lung cancer?
So I helped make a little bit of that data, although I'll confess, despite being a lung doc, I made more of the colorectal data than the lung data. But yeah, we just had a press release on adagrasib that had a 43% response rate in lung cancer, 80% disease control rate. And again, the toxicity was mostly GI stuff, right in line with what we expect with sotorasib and other TKIs. So I actually have more adagrasib experience at this point than sotorasib, but it's very similar. It's very similar in efficacy. It's very similar in toxicity. I think we need larger data sets on both before we even do the forbidden but omnipresent cross-trial comparisons, which frankly, we at some point have to do, because at some point we'll have to choose which drug to give our patients. But to my mind, the adagrasib story in lung cancer is exciting in part because it confirms the sotorasib story, that this isn't a one-off, that this really is a druggable target right now. And I'm very excited about combination efforts, because you and I think most of our friends have a consensus that we haven't gotten to frontline. I think we also have a consensus that our patients would echo rather strongly that we'd like to bury chemotherapy in the frontline, if not forever. And so it is exciting to look at the many combination efforts underway.
And you spoke a little bit of this. You presented these data to plenary at ESMO this year in colon cancer. And as you mentioned, again, worth repeating, G12C in colon cancer is a different animal. There, we would not expect a lot of efficacy with single agent therapy in lung cancer, but you showed some data with combination therapy. But the biology is very different between these two settings, right?
Yeah, so the resistance mechanisms are very different. They're fairly heterogeneous in lung cancer. We have other mutations in KRAS, particularly in switch-2, that seem common. We have all kinds of secondary mutations, including druggable ones. And we have transformation to squamous. We have and some others emerging. In colorectal, the dominant mechanism is feedback signaling through EGFR. And so in colorectal cancer, to get to really competitive, exciting response rate, we really needed to add on an EGFR inhibitor. And there we got to a response rate of 39%. And so I think for clinical purposes, I think what I want to say about that is that these disease states are not the same. And so unlike some other mutations, you can't just go out and give any patient with G12C an inhibitor, sotorasib now, adagrasib once it's approved. Colorectal cancer, you're really in a very low response rate with monotherapy. And so we need to wait for combination therapy to ultimately be approved for colorectal. There, the phase 3 is going against whatever fluoropyrimidine doublet the patient hadn't been previously exposed to. In lung cancer, we're also doing combination studies, but the combinations are different.
And, we've got these exciting drugs. There's a lot more coming, but we can only offer this to patients if we know about the mutation when it's present. So just, to repeat, the importance of testing and, granularity here matters. I think that in years past, KRAS present absent was enough because it was really just sort of a negative predictor for some of our other therapies. But now, we need the details. We need to know if it's KRAS G12C, where sotorasib, adagrasib are potentially options, versus G12V, G12D. There's different biology, different drugs. So if your assay is a PCR assay that's just telling you KRAS, codon 1213 mutation, that's not going to cut it anymore. NGS really a better way to go to find these. And I think you'll agree, Jared, as always, our testing rates could always be better than they are.
Right. So I think the most key points here is that every stage 4 non-squamous patient deserves comprehensive molecular testing. And then I think we need to be far more specific about what that testing is. So there are some PCR assays that give you, will tell you G12C present or absent, G13D, whatever, present or absent. But, I think we have a consensus that amongst thoracic experts that we're not always comfortable saying out loud in these kind of contexts. So I'm going to break the rules and go from talking about every patient should have broad comprehensive testing to being a little more specific. In my opinion, The best assay is a DNA next generation assay with an RNA fusion panel.
You need to know the details of your assay, and you need to know how to order what you want. You can't just order biomarker testing, NOS. That is not going to cut it. And so the field has moved beyond that, and we are responsible for knowing exactly what and how to order. And so details matter, as always, even more so today. Jared, I can't stress how important these data are. We've been waiting such a long time for a KRAS targeted option. It's really gratifying to see such an effective and well-tolerated drug now available. We have a lot more to come, but certainly a lot more work to do. Better predictive markers are needed to sort of maximize the benefit, understand why the drug doesn't work for everyone, how to overcome that, or better yet, prevent resistance, how to move them to the earlier settings, as you mentioned, in the context of immunotherapy, different combinations. Not to mention, we have all of these other KRAS mutations that also need treatment strategies. And some of the trials we've seen at both of our institutions look pretty promising. So I do want to be conscious of time. With that, Jared, thank you for your time. Thank you for your expertise, for your development of these drugs, and for this great discussion.
Thank you.
And to our listeners, thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.